Hi, everyone, and welcome to the Clinics in Sports Medicine podcast. I'm Megan Ashdown, Clinics Editor here at Elsevier. Clinics in Sports Medicine is a quarterly publication consisting of review articles focused on a central topic. Today, we will be discussing the January 2025 issue dedicated to building a sports medicine practice, Guide to Navigating the First 5 Years, guest edited by Dr. James Carr. Here now is a consulting editor, Dr. Gwathmeh, to lead the discussion, along with two authors from the issue, Dr. Brian Lau and Dr. Aaron Kasp. Hello, everyone, and welcome to the Clinics in Sports Medicine podcast. I'm Megan Ashdown, Clinics Editor here at Elsevier, and today we'll be discussing the January 2025 issue dedicated to building a sports medicine practice, guest edited by Dr. James Carr. Here now is the consulting editor, Dr. Gwathmeh, to lead the discussion, along with two authors from the issue.
Thank you, Megan. Yes, my name is Winston Gwathmeh from the University of Virginia, and I'm the consulting editor for the Clinics in Sports Medicine. And I'm very excited to discuss this issue. It's really near and dear to my heart. Dr. James Beamer Carr is a guest editor of this issue entitled Building a Sports Medicine Practice, Navigating the First 5 Years. And Dr. Carr put together a very strong issue that I think can become a primer for anybody who is starting to build a sports medicine practice to try to navigate some of the issues that might arise and provide some guidance to those as we get started in our practice. So Dr. Carr is joined here by Dr. Brian Lau from Duke and Dr. Aaron Kasp from University of Alabama, Birmingham. So actually, Dr. Carr, I'll let you introduce your guests here if you can. Introduce yourself. So go ahead, Beamer.
Yeah, sure. So I'm Dr. James Carr. I go by Beamer. I'm at the Hospital for Special Surgery, just in my fifth year now, post fellowship in practice. So let's see. I'll kick it over to Brian if you want to introduce yourself as well.
Yeah, so I'm Brian Lau. I'm at Duke University as well, in the same class as Beamer, and here in an academic practice, doing sports medicine, shoulder, knee, and ankle as well.
Yeah, I'm Aaron Kasp. I'm just starting my fourth year in practice at the University of Alabama, Birmingham. Similar to these guys, team physicians for me personally, a number of sports, and then I'm the hip guy here, but also do a wide variety of anything sports medicine.
Outstanding. So I am actually in my 12th year here, so this is not quite as germane to me, but Dr. Lau and Dr. Carr just finished their fifth year, and as you can see, Dr. Kasp is starting his fourth year. So these folks have done a good job navigating their first 5 years, and so I think they're great resources for the readership to understand kind of what trials and tribulations they might face. And so I do want to talk about this issue on a personal basis. Dr. Carr is actually a resident with me at the University of Virginia before he left for fellowship, and now he's doing an awesome job at the Hospital of Special Surgery. And this entire issue came to be because of an ICL that Dr. Carr did a couple of years ago. So, Dr. Carr, can you kind of explain to me kind of where this kind of came into your mind and how this issue came to be?
Yeah, absolutely. So I was actually a few years back attending an AOSSM nightcap webinar for emerging leaders. And Dr. Michael Sakati was the president at the time, and he was basically describing different ways young members to get involved in AOSSM. And one of the ways he suggested was to moderate an ICL, because he said if you're a young attending, you don't have to be the expert. If you're the moderator, you just kind of, facilitate the conversation. And I texted my buddy, Dave Bernholt, who is the same year as me, and he's at Campbell Clinic in Memphis. And I kind of jokingly texted, hey, I think I could give a full ICL on what not to do in your first 2 years of practice and kind of help people do better than the way I did with all the struggles I had. And he kind of replied, yeah, me too. And I kind of thought for the next couple of minutes, and I was like, I think there actually might be something there. I think that actually could be a good ICL. It could be a good topic. And so Dave and myself and Joe Lamplot, we put together a proposal. It was accepted, and it was much to our delight, received with a lot of great attendance. And Brian was on that ICL as well, who's joining us here tonight, and he was one of the people on the panels there. So it had a really strong representation and a lot of strong showing. And AOSSM that converted that into the resident and fellow symposium that is now a concurrent session and has about, I think, 3 hours dedicated at the annual meeting. And so it's kind of taken off from there. It's kind of become my baby from that. And I'm just glad to share it with everyone. And I think it really just spoke to the unspoken need and the silent majority of people that are recognizing the struggles of the first 5 years and now having more resources to be prepared and succeed better than ever.
Yeah, so actually, I attended that ICL myself. I was interested in seeing Dr. Carr and what he's putting together. And I think that when we go to these national meetings, people get up there and show how great some of their surgeries might be and how their outcomes are all so great. But I thought the panel that Dr. Carr put together showed some vulnerabilities, and I think that it really spoke to the people in the crowd who are I wouldn't necessarily say struggling with their own challenges, but trying to navigate these challenges. And so when the resident fellow panel came together, the AOSSM, I was a chair for that as well. And I really felt that I was going to speak to the trainees that were trying to get into the actual process, and it really has kind of taken off. And I think this current issue is sort of the seed or the offspring of all of that work that Dr. Carr did. So, Dr. Carr, and then one more question. We're going to start talk to other panelists. How do you put together your chapter list here, and like, what do you think were important topics to cover?
Yeah, so the chapter list, I basically just kind of wanted to go through the process of, each of the major milestones in the first couple years of practice. So, the first one, kind of choosing a job, the different types. So, I was able to luckily recruit some great experts, including Dr. Cass, to write chapters on how to pursue, different types of jobs, private practice, academic, and then just kind of going through the major highlights that I think are germane to people in their early career, how to build a sports practice, how to obtain and succeed in sports coverage at different levels, how to be involved in professional societies, how to, do research and make that a part of your early practice, how to handle the good times and the bad times, handling complications and mentorship and developing that and developing, those kind of networks that'll help you survive and all of those things, I don't think I had that list in mind when I started my practice, but as I went along, those were the big ones that I found myself really having to, build a foundation on. And I felt like it would be good to highlight those with our chapters so that, the readers can kind of pick what's germane to them and have a foundation to kind of get the wheels turning on how they're going to approach those things, even to the granular things of when to know when to change jobs or how to approach that. Because obviously it's fairly common in early practice to consider that or even do that. So, we try to be comprehensive, but also concise. And luckily, we had some great authors that did a phenomenal job.
Yeah, as a program director at an academic institution, I obviously deal with residents and fellows often, and I think that what's important to realize is they don't know what they don't know, and you really don't find out until you get out into the real world, just some of these things you might run into. And so, for instance, finding the right job. Dr. Cass wrote a nice chapter here on finding the right first job in an academic practice. Maybe, Aaron, maybe you can go into kind of how you found your job and what inspired you to write your chapter and how you put it together.
Sure. Me personally, going into a university setting, an academic setting, technically by the university standards, it has to be posted publicly. But the way I actually heard about the job was through word of mouth. The current division head here reached out to a bunch of known academicians, and they had heard about the job. And basically, Mark Miller looked up one day from his email and said, "Hey, are you interested in a job at UAB? I just got an email." So I said, "Sure." So he forwarded that along. I think hearing about the job is one thing. I think understanding the timeline for an academic and university-based job is another. It starts a full academic year. Mine was my chief year, so a year and a half before you would ever potentially start. Just because you're on the academic timeline and they're on the academic schedule, and that usually you don't even start to consider interviewing until the fall before. So like now would be interviewing for a full year from now. And through that process, I didn't have a lot of great information on what the academic process was going to be, just because most institutions are very different. But I thought that going through the process, I could find some general advice that I could write up and give to other people and some things to consider.
That's outstanding. So how'd you put together your chapter, Aaron? And then that was your personal story, but what would you suggest to the readers as far as how they can find their first academic job? or why academics versus private practice too? I mean, that's another good question.
Yeah, I think that's the first decision most people have to make. And I personally interviewed at private practices as well as in the academics. And when it comes down to it, that the academic side, you really have to think: do you like teaching? Do you want to be part of a big university in a department? There's definitely some support and infrastructure that comes along with that, but also, as everyone here can attest, there's some headaches with that as well. So you have to know what the give and take is for your own personality. I personally like being more part of a team, part of a department. I like the academic side. I like the teaching side of it, and being able to explore and expand the orthopedic research. So that's part of the reason I chose academic. In finding the job, there are not just part of the chapter, there are not that many academic openings in a given year, so it might be seasonal. So when you come out, there might be 3 academic sports medicine openings in the entire United States, and that's just what it is. I mean, universities don't hire just because somebody wants to go there. Universities hire for a need. Those tend to need to have university-based approval far ahead of time. So those are usually fairly well known, but I think reaching out to your own mentors, to your own academic mentors, as the sports medicine community gets very small, so those academic mentors have probably heard the rumblings of a position opening up. So that starts the job search, and you just have to be prepared for sort of looking ahead long in advance, because those the universities generally don't hire on a whim. Those, like I said, those positions have to get approval. Reach out to your prior mentors and just look on university websites, because again, all those are publicly posted.
So academics ends up being the direction that you went. Also, Dr. Lau went academically as well. Brian, maybe you can kind of give me a sense of what it was like for you to get your job, and then we'll talk about your chapter here in a second.
Yeah, so I think decision between academics or private practice. I think there's no wrong answer. You just have to to figure out what works best for you and what you want to decide to do. And for me, research has always been a big part of what I had done in residency and going forward, and spending a year doing research and getting extra degrees and stuff. So that was always something I knew I wanted to do. And so that was, I made that choice pretty early. And I did a lot of cold emails actually to academic practices and regions, where I kind of split up the country in different regions of where I think I might want to be. And there actually was not, at the time when I started, an opportunity here at Duke. Um, it was fortunate that things were going well and people liked me here, and it didn't come until about late November, December when they created a spot. They said they really wanted me, but I didn't accept right away. I interviewed at a bunch of different places around the country, entertained 3 different offers, and waited not until April, May to sign. Was really kind of methodical about interviewing in different places and making sure I got everything and evaluated everything out. Um, but so that's how it worked out for me. I was just really lucky that it worked out, the time worked out. Um, but I think the big thing is, as you're deciding, is they say, well, there's 3 things that you can have. You can have the money, you can have the job, or you can have the location. Figure out which one's most important for you, and then break up the country in different regions and academic versus private practice, and going from there.
You sound like the true Duke recruit, weighing all these different options and choosing Duke at the last minute. I love my house. You're the 5-star. You're not a one and done. You're there for you're right there. Oh,
I think they were scared to let me out into the world, so I'm still technically not graduated. It's probably what actually is.
Hey, nothing wrong with being a PGY10. It's all good.
Yeah. Still going.
I will speak to that. What you both just mentioned, the most stressful and first sort of obstacle into navigating the first 5 years is getting that job, and finding the right job and making sure you're in the right location. And I think you spoke to it very well there, Brian. Let's talk about your research. You discussed that kind of in that answer there. So how do you do research early in your career? You're trying to build a practice. Like, how did you write this chapter?
Yeah, so I obviously wrote from experience, but also had some co-authors there, Sarah Lander and Chris Schultz, both who are also in academic practice, but so also in parts of academic research and that. I think the biggest difference of research as a trainee and as a faculty is that nothing is there for you as faculty, right? Like you don't have any patients yet, you have no expertise yet, you have no money yet. And most research for a lot of people as they're getting through training is just try to get to the next level, right? So you're jumping on projects that you're taking some thought about, trying to get as much stuff done and you're not really truly asking your own questions. And I think that can be a real challenge. And so there are some people who are very fortunate, who have exactly an idea of what they want for their research to be. And and Martha Murray is a great example of that. She knew since she was in med student exactly she was going to study ACL repairs, and really stuck with it and said that and found a job that will let her do that. I think for most people, and myself included, you don't know what your practice is actually going to be like. And so I think the key is just kind of set up the infrastructure first, and then kind of seeing what comes in through the door and see how your practice shakes out. Because no matter what anyone tells you, your practice is probably not going to be exactly what you thought it was going to be. And so it's kind of more of an opportunistic kind of approach to it. And so the biggest thing was kind of, setting up your PROs early, for whatever things you might be interested in. Because when your clinics aren't busy yet, your clinical staff can kind of prioritize that, make sure it gets done. So you kind of have a process for that. Keeping really good case logs. So, you did that as a trainee, so it shouldn't be too much of a stretch to do it as a faculty member. Keep track of all your cases, because before you know it, you're going to be a few years in and have a whole long list of cases that you have done and be able to look at those pretty quickly. So then you have your PROs and your cases, you know what cases you're doing, and you can kind of see how your practice is shaking out too. And so those are kind of the basic early things, but for anyone going to practice, click PROs early, set up your databases, but then also just kind of see what your institution has, what your community has, and what opportunities there are there. You might have a really strong military population nearby, or a certain high incidence of like ultimate frisbee or whatever it is. Something unique that's in your community, and leveraging that as well. So that's kind of how we kind of catered the chapter, like what should everyone do, and then how can you leverage opportunities in your community and your practice and your university.
You bring up a good point, Brian. Your first few years in practice, you might not be as clinically busy as you want to be, but you can use that time wisely to establish infrastructure, establish algorithms and you will become busy. I think that part of this issue, which is nice, is it does encourage you to realize that despite the struggles, there is progress to be made. And so I think this first few years is a great opportunity to really build who you want to be as a surgeon, as a researcher, whatever else might be. However, talking with Dr. Carr, one of the most important sort of obstacles you have to get over is a board. So we talked about Dr. Cass' chapter and Dr. Lau's chapter. Dr. Carr wrote a nice chapter on ABOS Part 2. Maybe you can talk about kind of how you put together that chapter, Beamer.
Yeah. So, my job was a little unique in that I was mostly based out of an ambulatory surgery center, not hospital based, specifically not academic based or university based. So I was a little bit on an island. And so I didn't have a lot of people there that had recently gone through boards, or, really had an interest in mentoring me through that process at my location. And so at my satellite. So I kind of like, learned some difficult things along the way when I went through ABOS. So, luckily I had some great advice from, people like you, Winston, and my other mentors from UVA and fellowship that kind of gave me a good foundation. But, I think my biggest piece of advice in the chapter is you just got to pretend like each day from day one is board collection period, because you never know what's going to happen with ABOS. So I was actually a year delayed, because I switched, from the main campus to the satellite. After the window for where you had to be established. So all of my colleagues ended up having their boards during COVID and the pandemic. And so ABOS basically expanded the window of board collection to prior to the normal collection period after the fact. So, cases that weren't intended to be in board collection ended up being in board collection. So that was a really powerful moment that showed like, don't try to sneak in a case that might be, questionable before boards, because it might end up on boards, or you could get a complication during boards, and then it's all fair game. So we shouldn't be doing that anyways in practice, but especially when you're navigating, board collection. So and I think too, there's just things that are just kind of little details that if you don't know, they can be a pain afterwards. Like all the letters you need from your, chief of nursing and chief of anesthesia and chief of the department from every place that you operate in. So if you're at one place, it's easy, but if you go to 2 or 3 hospitals or ASCs, then it becomes harder. You need surgical consent forms for every patient. I didn't know that at the time, so I was backtracking at the end, trying to find all the surgical consents and having people pull records and hoping that they were there appropriately, and luckily they were. But just extra stress that I wish I would have done on the front end. So a lot of my chapters is basically how to set up an infrastructure, kind of like Brian mentioned with research, how to set up an infrastructure, from day one to make sure you're ready for keeping track of your cases, having help from office staff that can, keep track of things for you and give you the contacts for the letters and everything else that you need and, keep track of your application status and all that kind of stuff. So, um, and I think too, just trying to encourage them, like, I think I hate to sound old, but like back in my day when I was a resident, I remember the chief stressing out, and then the general advice was, "Oh, everyone passes. It's like 90+% success rate, 98%. Don't worry about it. You're fine. You're a good surgeon." And that was kind of the advice I got coming out of fellowship. "Oh, you're a good surgeon. You're fine. You'll be good. Don't worry. You're a nice guy. Like people like you." And everyone kind of passes. And the last couple of years has been, in the 80s for pass rate, not the 90s. So, that's still pretty good, but that's 15-20% that's not passing. That's not an insignificant number. So, I think there's some pitfalls that have come about. Using industry driven techniques that aren't backed by research yet, can be a big pitfall. And just different things that I think the readers need to be aware of. And I definitely try to highlight those, just kind of the general process, and then a little like FYI, like, here's some ways that it's changing, and just be aware of it. So, hopefully it just gets everyone prepared and takes a little bit of the stress out of it. And most people still do pass. So, don't stress too much. But I think if you take it seriously and load the boat with mentors, you'll be fine.
I'd like to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we're discussing today by visiting us.elsevierhealth.com/expert.
Well, your chapter is like a how to pass the board, which I think if I was my first or second year of practice and I was preparing to, actually, I think right before I started my board, my case, like, starting your case collection, read that chapter. I think you'll be in good shape. Because again, you don't know. And then suddenly you're 4 or 5 months into your board collection, you realize you should have been collecting certain aspects of your documentation. And that chapter helps you to understand kind of the checklist, what you need to go through. So absolutely, it's not a fun obstacle to get through. Definitely get through it. It's the most important thing, because 85% success rate, but there's a 15% failure rate. And if you're at 15%, that's a pretty rough year. So
Yes.
I'm going to turn the tables.
Instant. I want to add one thing to that boards thing. So part of boards, actually, there is a PRO component to it. So
Yeah.
setting up PROs can, help you for your boards as well. Just kind of streamlining all that early on. So that goes together. I mean, you're gonna have to do it for boards anyways. So setting up for research is easy enough.
Well, to the PRO point, Brian, I think that if you're not tracking your outcomes, or at least having some idea of how you're doing, how do you get better? Like, how do you understand like what your interventions are doing are a good thing or not? So I do think that I would stress, and that's the first thing you mentioned when you talk about your chapters, how important it is to set up your PROs with your patient reported outcomes. What system do you use, Brian? Just out of curiosity.
So I actually do it through Epic. So it's
Mhm.
not a separate file. So if you're using Epic, which I think probably most places are now, you can set up pretty easily, and you can review it. I'd say I did not doing it the last couple of years, but first couple of years, I would actually review the PROs of all my patients, because you have a little more time. Clinics are a little bit less busy, and it also convinces them to do the surveys because they know you're looking at it too, right?
Yeah.
And so we do it through Epic, which makes it easy because I can pull up in the room for them. And then I also would encourage early on to, again, not as busy, follow your patients out a little bit longer too, because you want to see how they're doing and you get an idea what their questions are going to be, what problems that come up, too. And then you're also getting your PROs. So, yeah, I mean, that's how we did. Some people here, have tried, RedCap surveys. Some people do like Patient IQ is, a third party, user you can use as well. Obviously that costs money, but that's an opportunity for that as well. So I think any of that can work. Just find out what works in your system.
Well, on that note, I'm going to turn the tables on myself. Beamer, maybe you can take it from here and talk about why you asked me to write this chapter.
Yeah, no, absolutely. So, yeah, Winston, I appreciate you let me take the mic for a bit. So, one of the chapters that I really wanted to have in this issue was basically how to manage and deal with complications. And I know for me, I kind of started off with this unrealistic idea that I'm gonna minimize my complications and I'm just gonna be a careful surgeon and everything will go smoothly in the OR and my patients will do fine and I'll make the right clinical decisions, and it'll be good. And it's kind of like Mike Tyson would say, every boxer's got a plan until he gets punched in the mouth, or punched in the face, and then you're kind of just reeling and you forget the game plan, and it can be hard. So, um, you know, it just being one of your mentees from residency, and just seeing how humble you were with your patients, and being very honest about your outcomes, and not skirting away if a patient was struggling or having a tough time. You really would lean into them, and you'd really just lean in and spend more time with them, and call them more frequently, and bring them into clinic more frequently. I thought it was a great example of just how to handle those complications. So, I asked you to write a chapter on how to handle complications early in practice, and I thought it was one of the most kind of honest, heartfelt chapters, and really kind of a highlight of the issue. And I would just love to maybe pick your brain for a question or two of how did you develop your approach to handling complications? Because I think, for all the listeners in early practice, and even late practice surgeons, complications happen, and it hurts and it's hard, especially when you have your first couple ones. So I would just love to kind of hear just how you came to where you are today. First of all, I guess would be how you handle complications personally. What are your kind of pearls when they happen? And number two, like, how did you kind of get to that point where you've developed the approach that you have?
At the risk of being the expert in this domain, which
I did not ask you to write this because I thought you were the expert in complications. I thought you were the expert at how to approach them the right way. We'll put it that way.
well, one, if you don't have complications you're not operating, I do think it's something that we face as physicians, and it's hard to even explain it to a non-physician, like how, like the person, a patient gives you the responsibility of putting them to sleep, and cutting into them, and changing their anatomy or reconstructing something that's torn. I think it's a huge privilege for us, and I think we have to take it very seriously. And when I wrote this chapter, if you look at it, I wrote it by myself. A lot of times, it's 12 years in the practice, you had a trainee to help you or something like that. But I thought this was a really personal chapter to me because I do think it's important to be able to face your complications kind of head on. They will happen, and your patients want to know that you're invested in their outcome. And so I always make it a point to, when any patient, preoperatively, we talk about the surgery that we plan to do, and make sure you understand their expectations are set, so they understand what a good outcome is, what a reasonable outcome is, what a bad outcome might be. And so if you establish that level of trust with the patient, the complications that do arise are much easier to manage, because they feel like you're part of the team. Anytime I operate on a joint, I say, this is no longer your shoulder, it's our shoulder. We're in this together. And from the moment you have your surgery until you have your full recovery and you're throwing the baseball again, and you're back at work, I mean, this is our shoulder. We're in this together. And so I do think that if you take on that responsibility, and the patient knows that you're kind of in it with them, and something bad happens, they know that it's happened to you too. I think one thing that people don't realize, that complications happen to two people. They happen to the patient, they happen to the surgeon. And if you carry that burden with you as a young surgeon, it can really, really compromise your ability to take care of other patients, because you're constantly thinking about that complication. So as I put together this chapter, I try to realize what I like to do is, there's not a lot of great science behind it, because there really isn't a great isn't literature necessarily on how to manage complications. A lot of it's just wisdom and gestalt, and talking to your mentors, understanding what they did. And so as I read this chapter, I just kind of felt like what I would want people to think about how I handle things. And so I did put a lot of thought and a lot of time into it. I think at the end of the day, your patient wants to know that you're in it with them. And I also think that for the surgeon who's trying to develop a practice, you have to figure out some way to compartmentalize those bad things that happen to you. And talking about PROs, Brian, I think PROs are important, because you'll start to perseverate on the one or two patients that are doing poorly. You have that one or two patients that came back, and they're not recovering the way you expect them to, but you had 100 patients who are doing great. And if you collect PROs, what you'll realize is the curve on your rotator cuffs and your ACLs, all that stuff, is all very, very positive. You've done a great job for 90% of your patients. It's just a handful that might get you down. And I swear to God, you go to bed at night thinking about that one person who's doing poorly, and not the 9 people you're doing great. So I think that's what my chapter came to be, and I hope that it's well received. But thank you for making me the expert there, Beamer. I do appreciate it. And I'm happy to talk about it all day long. I only had one complication my entire career, so I guess that's where I went like that.
Yeah, exactly. And clinic is hard. And one thing that I remember you kind of teaching me, Winston, is that clinic is a very self-selecting process, meaning, all the people that those 9 out of 10 that are out there doing great back at work, playing their sport, they're not coming in to say, hey, thanks, doc. Like, it's been a year out. Like, I love my shoulder still. You're the man. Awesome. Great. The ones that come back are the ones that still have a little pain, still aren't quite where they want to be, or something just not quite going the way they want it to. But it's easy to, get to the end of clinic and just feel like you're not a good surgeon, or you're struggling, or your patients are struggling. And I think you're right. Having that global perspective is important. And um, to that end, I would like, so you talked a lot about you build trust with the patient, and that helps, kind of set the table if a complication were to happen. Let's say, something does happen. You have, something happen in the OR that, you weren't expecting, or, patient comes back with, stiff joint, or possibly infection, or something along those lines. How did you build a network around you with colleagues or mentors, or other people, to be able to talk and process through this? Because I think one of the hard things that I've realized for myself and others is, we have a complication. A lot of times we want to hide it. Even if we aggressively approach it with the patient, we don't want our colleagues to know. We're afraid we're going to be perceived as a bad surgeon. We don't want people talking about us. It can be a very isolating experience if you let it be. And if I remember correctly, I think you talk a little bit in your chapter just about, having trusted mentors, or colleagues that you can lean on. And, how did you go about building that kind of trust with colleagues and mentors? Um, and how would you maybe give advice to, young surgeons on approaching that side of managing a complication?
Well, to put it back on you, I wrote back to your ICL that you and Brian did a couple years ago, and how honest all you all were with each other. I think you have a lot of peers. I think the one thing the thing is not recognized about sports medicine, about orthopedics, is that you kind of come through this whole process with kind of like a group of people. You're all kind of all doing it together. You're kind of all growing as a group, and you and Brian and Aaron are all kind of similar as far as where you are in practice. So I think the first people I tend to talk to are my near peers, people who were my fellowship classmates, my residency classmates, those people who are kind of going through the same struggles as me. Because, for me, like talking to a Dr. Dudek or a Dr. Miller is a little bit different because they're so much further along with it. I'm not sure if they understand my perspective nearly as well. So I do think that the group, and just looking at your group of authors that you have in this issue right here, that right there is a network in of itself. Those people you came up with, and people who are early in their practice, So I think having that near peer group, and then also having a select handful of mentors who you train with, perhaps when things get really bad. And I remember calling Dr. Thomas Bird, who taught me how to do hip scopes, after a really bad day. I had a bad hip scope or something like that, and I called him, and he's only Dr. Bird can do this. He came right back at it. Well, I had a bad, and he told me about a bad day he had too that same day, where he felt like he was all thumbs, and he had some visiting surgeons from like Brazil watching him, and he said he felt like he was just floundering. I'm like, man, but it can happen to Bird, it can happen to anybody. And so I do think they're all kind of in this together, and no one is immune to feeling bad. But I think that what it comes down to is this entire issue helps you navigate those types of things. And complications are one thing. There's other struggles you're going to have as a young surgeon. But that's why I like your issue so much, Beamer.
And I do appreciate that, the heartfelt chapter that you gave, and I encourage every reader to check that out, because, like you said, they happen. I think 90% of surgeons will admit complications and, talk about them. And the other 10% are lying about their complications. So it definitely happens to everyone. And the more honest and vulnerable we can be, the more freeing it is, and it helps. I don't think anyone wants to talk to someone who says, "Oh, I've never, have done something wrong," because we know that's not true. So I really appreciate you furthering that vulnerability on the topic. So I really appreciate you there.
Well, thanks. I'm glad we talked about that. We can move on from complications to that. I think we've had a nice discussion about this entire issue. Um, I think that the reader who actually reads all these different chapters will be in a pretty good place to kind of get things going. So I do appreciate what you put together here, Beamer, and all the efforts. So thank you, Dr. Carr, for this outstanding issue. I think as we're closing down this podcast, which I think went really well, I just kind of go around the panel, start with Dr. Cass. Maybe just a pearls of wisdom you can give to that early surgeon trying to navigate his first 5 years. So Dr. Cass, what would you give as that pearl? And we'll go to Dr. Lau and Dr. Carr.
I would say you really have to rely on your training. You're going to go into an environment where there's a lot of other surgeons who have a lot more mature practices. And maybe you want to be busy. Maybe you want to build up the practice that they have. So you want to be able to operate more. Maybe you see some stuff going on that is maybe a little less indicated, but those guys are super busy. I would say keep doing what you know should be done. Fight the temptation to do unindicated things just for the sake of being busy, because it'll burn you in the long run. And those patients that you keep out of the operating room, I promise you, will send their friends and family to you, because they will appreciate that way more than a successful surgery.
How about you, Dr. Lau?
A couple words of wisdom for anyone who's starting practice. One is be patient. You're going to get there. Do really good with your patients. Take your time. You're going to have more time, so take time with the patients, both in the clinic and the OR. Explain things, see them follow through, make sure they're doing well. And that part of that is PROs. I know we talked about it a couple of times. Be flexible. Okay. So you may not have the exact practice you want right away, and just be flexible and just with the things that come in the door, and treat them well. And then, highlighting a little bit of the complications part, it was mentioned, it's going to happen. Load the boat, talk to your mentors, talk to your partners, get people involved. Don't shy away. And that's, these are all hard lessons I learned myself. It's hard to admit that, and that being vulnerable when those complications happen, and just load the boat, trust your mentors, trust your partners, trust your colleagues, maybe not, the people that you met along the way. And so those are things that I would, big tips for the first couple of years. It's tough. Most learning happens in those first several years.
Experience is a very tough teacher. That's what Dr. Berger always telling me. The experience is what teaches you, but the process of learning that is not all that much fun. All right, guest editor, Dr. Beamer Carr, what is your last words of wisdom for the readership?
Yeah, I think I echo everything that's been said. I like the saying, so in the Mets minor league complex, there's a saying, a sign posted that says direction is more important than speed. And I think that's important. You have to kind of ask, where do I want to go in my career? What kind of doctor do I want to be? And you need to make sure that you set yourself up to go in that direction. It's probably going to be slower than you want it to be starting off, and that's okay. But as long as you're kind of heading in that direction, whether it's with research or, the type of practice or, what you're involved in is important. Learn to say no. You'll say yes to a lot of things being the young person, and you'll kind of have to do your young surgeon duties by, taking on certain cases and committees and, involvement, depending on the group and the practice. And that's good. And you should get involved, but learn when to say no. And as things don't line up with, your goals, and it's okay to say no. And I think just have fun with it. Like what we do, it's amazing. We get, kind of like you alluded to, Winston, patients come to us with their struggles and their problems and their injuries, and they trust us to make them whole again and to help them. And that's an honor, and it's a privilege. And hopefully it's something that gives us great intrinsic value in what we do, and satisfaction. And it should be fun. It's a fun process. It may not feel like a lot of fun the first couple of years. It was hard for me to describe it as fun, but it still was in its own way. And it becomes more fun as you go along and get that experience. So yeah, I would say direction is more important than speed, and have fun with it, and it'll be a great time to look back on.
Thank you, Dr. Carr. So my word of wisdom would be to the young surgeons to read this issue of Clinics in Sports Medicine. It's got absolutely everything you possibly could need in order to be successful in your first 5 years. Thank you to Dr. Beamer Carr. So with that, Dr. Aaron Cass, Dr. Brian Lau, Dr. Beamer Carr, thank you for being a part of this podcast and for your outstanding contribution. So with that, we'll adjourn this podcast.
Thank you for joining us for this edition of the Clinics in Sports Medicine podcast. Clinics in Sports Medicine is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms, Clinical Key, and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Clinics in Sports Medicine podcast.